Joe, I'm curious. I mean, this is going to require a culture shift in how we think about prostate cancer, how we think about germline, how we think about somatic. How is that going to translate into the real world? How do we convince our colleagues around that this niche, however big or small it is, this niche, deserves, screening in the entire population, or can we pick out sort of clinical disease states or patient phenotypes that we should be, definitely screening versus sort of people who are maybe a little bit less suspicious?
Well, I guess we've seen data emerging gradually over the years, but I agree with Chuck. I think this data, which is showing a survival benefit for a mutation-targeted therapy, is really going to accelerate that involvement. And we're really going to have to get to know our molecular pathologists very well now. There was a fantastic session at ESMO yesterday with Mark Rubin, Johan de Bono, Ros Eels, really giving a really tour de force about the full state of the art with regards really genomics in prostate cancer generally. Of course, predicting response to therapy is one part of it, prognostication is the other, but it's very, very clear now that, as Ros Eels says, we have a tsunami coming our way. We're going to have to be ready for this, first of all, in deciding which patients will benefit from a DNA damage targeted therapies, but also really to understand it in much more detail. And Johan really gave a great talk yesterday talking about the complexity of it. And as you said, Chuck, whether it's single allele loss or biallelic, I mean, it's not just a question of, like in breast cancer, ER positive, ER negative. It's way more complex than that. Yeah. And so I think we're just seeing the beginning, and even that's much more complex than we talk about.
The other factor is, rarely do you see a patient with one mutation, right? If you're sequencing a lot of your prostate cancer patients, you may get 3 with BRCA2 alterations, all pathogenic BRCA2 alterations, but one has RB1 loss, one has P53 loss, one has P10, P53, and RB loss. Those are 3 different patients molecularly, and we're just beginning to scratch the surface of what all that means.
But I can't emphasize enough, you don't know any of that unless you profile.
Yeah.
And I think this tsunami, it's been there. We've been ignoring it.
But I think
and we haven't had the tools. Yeah. We haven't had the tools to treat or the tools to diagnose, but we have
having a tool
now.
to treat that will open up, I think will really open up the floodgates.
And I think this is the thing now, we really got to change our mindset, that this becomes the norm, not the exception in our patient management.
I don't think, at least from European perspective, that we've been ignoring it, but you have to understand that so far it was confined to a very privileged world of academic institution. Mm-hmm. And actually that tsunami come with a financial tsunami. So there is a caveat around that, is that I don't think we've been not screening for science reason. We've been not screening because it comes with a huge cost. And if you look at most healthcare system, except the big 5, we have like in the US, if you can pay for it, you got it. If you don't have money, you don't pay for it. In many European countries, for instance, we're really reaching the limit for the sustainability of the healthcare system. And when you do a quick calculation, introducing this drug means introducing in the community the testing. And what scares me about presentation like Johan de Bono is that we are very far away of having an easy, cheap point-of-care test for DNA repair mutation, including ATM. So meaning that we still need to go to complex, expensive genetic technology. And when people are gonna add the price of that to the price of the drug, we're gonna have to make a crucial choice. For instance, when you see the difference in response between BRCA2 and ATM, it's very likely that in many countries, payer will ask 2 models. They're gonna ask a value-based model for BRCA2 and a value-based model from ATM. So there is huge complexity. And the second thing is that when you look at, okay, that's great because basically it's the first in class true precision study medicine. But when you take time, you sit down, you say, wow, my God, there's still a lot of frustration. First, we're gonna have to cope with all the patients who don't have this mutation, okay? That's 4 out of 5, best case scenario. And the second is that even for those who have the mutation, still the benefit remain modest. So we, especially when we speak to patients, I would say that, yes, that's great trial. Probably in 15 years from now, this is going to be the reference as when we enter the field of precision medicine in prostate cancer. But still, we should restrain of being too over-enthusiastic. I think that trial result is generating a lot of very important ethical and practical questions.
I mean, it's much like when Charted was reported. It was the first study, and then others came, and more will come. And I would just say that I agree with you on the cost, Bertrand, but we've seen on the research laboratory side, the cost of doing this kind of profiling had come way down. I think clinically we could see those costs come down as well. I'm not convinced that we've lost the value care argument at this point.
I'm not worried about the cost of the test, because if the test costs the same as about 1 month of therapy with an alternative drug that you're not going to use, you're saving money, right? If you're not choosing second-line enzalutamide or abiraterone for a patient, but rather are putting them on olaparib because they have a BRCA2 alteration, you're not only helping the patient, but you're avoiding unnecessary, ineffective care. You're probably also delaying or avoiding complications of the disease that may arise. I do think, though, that I do think there's an important point about the patients, the spectrum of response in the patients with the mutations. It used to be that I thought when I picked up a BRCA2 mutation, I was going to prescribe a PARP inhibitor with so much optimism, and I still am very optimistic, and it's really great to make that call. But what we're seeing is the response proportion to these drugs is about 50%. It's not 100%. And so that's an interesting story. Why is that the case? What are the mutations? How can we do better? What
are the other targets?
Yeah.
So actually, I want to pick up on 2 points. One is what we hear in the early reports, and this is the same with lutetium PSMA, we hear about the extreme good responder, and we think that's going to happen to everyone. And we'll see what happens with the randomized phase 3 trials, and we see this. The other thing I think when we're talking to patients about, I'm going to biopsy you to get a specimen or try and work out if you have what we think are the 3 leading candidates, and it's probably going to be biallelic BRCA2 right now, and that's going to be the main predominant one. Some ATMs, maybe, and some rarely the BRCA ones. They're the big ones. There may be some other smatterings, but let's actually say 100 patients, you're going to biopsy 100 patients, and probably 10% of them actually have something that may be relevant, of which 50% will actually have a response. So even at the point of biopsy, I think we have to start the patient's expectation that we're going for it, but it's no guarantee.
Hopefully all that biopsying will lead to some discoveries that will help the 80% who aren't currently benefiting.
For the next
right?
iteration.
And then the other point is, we haven't talked about this, it's a minor consideration, but is these MSI high cases that you pick up. That's the difference between life and death. When you identify an MSI high case, that makes many biopsies, that makes that biopsy worthwhile, and you don't know it until you see it.
And but the incidence again is still
3%.
But
Yeah.
it's zero.
But when you get
it's zero if you don't check.
No, I'm saying check it.
Right.
But actually don't say, look, you really need this. This is the difference between life and death when you're starting at 100%.
That's right. Consider the cost and morbidity of the biopsy versus putting everybody on pembrolizumab, for example.
Oh, no, I'm 100% in there. It's just that this issue of desperation oncology, like you said, pembrolizumab on hospice because you got a shot.